Hello, my name is Chelsea Binder. I'm going to be presenting Domain 4, the effective management of rapidly changing situations. It's from Chapter 7 of the Benner book, which I have here to share some exemplars from. The first competency in this domain is skilled performance in extreme life-threatening emergencies, a rapid grasp of the problem. So this is the nurse's ability to grasp the problem quickly, intervene appropriately, and assess and mobilize the help that is available to them, such as equipment, other staff members, just anything in reach medications. I'm going to be sharing an exemplar from the book. It's going to be exemplar 1 from page 110. And this is from an expert nurse. At approximately 7:30 p.m. on a Friday afternoon, the emergency room was busy. Many of our staff were tied up in the major trauma room with an automobile accident. At this point, the paramedics arrived with a 50-year-old woman who was complaining of chest pressure, which had begun while she was gardening. Premature ventricular contractions were treated at the scene with the lidocaine bolus, and an IV was running. I met the patient and the paramedics at the door, and I began talking to the patient. As we entered room 2, the patient said, "I'm going to faint." The monitor showed ventricular fibrillation. I instructed the paramedic to begin chest compression as I rushed to plug in the defibrillator and call for the physician. The physician arrived just as I was ready to defibrillate her and offered to intubate her. I indicated that I thought it wouldn't be necessary and went ahead with the defibrillation, since I knew that the time of onset and wanted to interrupt the arrhythmia as soon as possible. I then defibrillated the patient, who responded immediately. She, in fact, requested to go home for a shower. Her monitor showed a regular sinus rhythm, and her vital signs were within normal limits. This incident was satisfying because the patient made a full recovery. It turns out that the problem was the life-threatening arrhythmia and not a myocardial infarction. She was able to go home in 3 days. From this exemplar from an expert nurse, she was able to grasp the problem immediately. She met the paramedics and the patient at the door. She was able to talk to the patient a little bit until she said she felt like she was going to faint. She intervened appropriately by getting the defibrillator, having the paramedic do the chest compressions, and even telling the physician that she thought it wouldn't be a good idea to intubate since she was about to defibrillate. And it turns out that it helped save her life, and she only spent 3 days in the hospital. So she was able to assess and mobilize the help that was available, such as the other staff, the defibrillator, and being able to talk to the patient. The next competency that I'll be talking about is contingency management, the rapid matching of demands and resources in emergency situations. Nurses are most continually present on the unit, and they're most aware of the big picture, as we all know from being in clinical or working at a hospital, that you always can find a nurse around. Unlike a physician or any other healthcare provider, it may be quite difficult to find them. You may have to call them and wait, but you can always find a nurse on the floor. So nurses are the overseers of the unit. They're aware of and use available resources. They usually know anything about the unit. You could ask any one of them and they'll give you an answer or tell you where to find the answer. So with the contingency management, I'm going to be sharing an exemplar from page 113 from an expert nurse, and she just describes the typical/atypical day in the emergency room. Excuse me. This was a Sunday, a 3 to 11 shift in the emergency department, going smoothly until approximately 9 p.m. One medically urgent patient in a large treatment room, another chest pain arrives by private car, and a severe asthmatic patient by the same mode. 2 ambulance rings down, another chest pain, and a GI bleed. All 4 nurses are tied up assessing and initiating treatment. Ambulance rings down, insulin shock coming in, goes to trauma room. 2 nurses needed. A 17-month-old baby arrives by private car with febrile seizures, called the supervisor. Male arrives by private car, overdose of pills and booze, very belligerent patient. Is in large treatment room and must be moved to trauma room 1. Move asthmatic and GI bleed to holding room with 1 nurse. GI bleed is going to go for an X-ray for arteriograms. Supervisor and one nurse are in trauma room with seizure and insulin shock. Both patients are becoming stabilized. Medically urgent case has been seen by consultant, is ready for admission to the ICU. The belligerent patient moved to a private room. Consultant seeing most severe chest pain going to CCU, and the febrile seizure to go home. This type of 2 hours spent in an emergency room is typical. One must continually assess the state of the unit, keep the flow going. Nursing does this since the physician seldom knows the overall picture. So again, this shows that the nurse is the one that's overseeing the whole unit. They're aware of all the resources, who to contact, what to do, exactly where to put patients, especially in this situation in an emergency room is where you can most likely think about these scenarios. That she got all the patients in where they needed to be, what room, she knew what nurse to assign them to, physicians to call, where they're going, where they're being transferred to. I'm sure with all of this, she was able to calm the family down, calm the patient down, be able to get everyone some answers that they needed. The next is identifying and managing a patient crisis until a physician is available. So nurses are most often confronted with medical crises that require immediate intervention. Considerable knowledge and skill are needed to determine the severity of the situation. Nurses decide what is needed to be done before a response from a physician, and nurses must work between the lines of safe nursing practice and jeopardizing the patient's life by withholding necessary life-sustaining measures. For this, I'm going to read an exemplar from the book. I'm going to be reading exemplar 1 on page 116. This is again an expert nurse. I came on duty at 3 p.m. and was assigned to a fresh post-op open heart surgery. The patient had returned to the ICU around 11 a.m. that day and had all the usual paraphernalia for post-ops: IVs, respirator, chest tubes, Foley catheters, etc. The patient had a log of IV fluids and blood replacement on days. This is the usual procedure for open heart surgery. You give them lots of fluids at first. They usually have had mannitol, and then you level off. Blood pressure will drop as the patient begins to warm up and dilate peripherally, but will usually level off soon. However, this patient continued to be hypovolemic, low blood pressure, low central venous pressure, and was diuresing in enormous amounts. We were pouring fluids in an attempt to catch up, but we were managing, barely, to stay even with output. The patient by this time, around 4:35 p.m., was fully warm, so clearly something else was amiss here. I telephoned the surgeon's exchange, but was not able to locate him. The exchange promised that they would have him call as soon as possible. I tried to contact the assistant, but he was off call to another doctor who was not terribly familiar with post-op open heart surgery. Meanwhile, we were pouring in fluids, blood, and packed cells. Without orders, just to stay even for the patient was continuing this diuresis. I began reviewing the possible causes for this and decided a likely one was hyperglycemia. I then ordered a blood glucose level, and the results came back, more than 600 milligrams percent. About this time, the assistant surgeon had come back on call, and I was finally able to contact him. He prescribed for the patient on the basis of the blood glucose level, and we were then able to stabilize the patient. In this exemplar from this expert nurse, he or she was able to confront the medical crisis and intervene immediately. They had knowledge and skills that were needed to determine what they needed to do, even without orders. So you're crossing that line of your nursing practice and saving the patient's life. You need to decide what has to be done before you even hear a response. You can't just have the patient lay there and possibly die from this this thing that's going on from their surgery, this adverse reaction or whatever it may be, the hyperglycemia. You have to do something. You can't just sit around waiting for a call or a physician to show up. And that's exactly what this nurse had done. She said blood and packed cells, fluids without any orders. So she did that in order to save the patient's life, even though it's between the lines of safe nursing practice. The significance to nursing practice and patient care. Again, Nurses are consistently on the unit and recognize crisis immediately. It is the nurse who is constantly assessing the patient, answering call bells. They can see changes with patients even before the patients may even know what's going on. There's a fine line between what the nurses can do and what they should do in a crisis. For example, the last exemplar I shared, they were giving blood and fluids without any orders just to keep this patient alive. The patient care would be compromised if the nurses did not act quickly, and there are better patient outcomes when nurses act on a crisis. If the nurse was just waiting for a physician to call or a physician to show up to give orders and refused to do anything, the patient would have most likely died from this hyperglycemia. Impact on the interdisciplinary team and patient safety. Like I said, nurses are going beyond their scope of practice in order to save their patients' lives. They perform these tasks without orders, and the nurses fail to document and legitimatize this major area of our actual practice. Usually, the physician will just sign off on orders after it had happened, which does happen. Patient safety can be compromised depending what the nurse did, if it helped or if it made it worse. In conclusion, nurses must be able to manage a crisis and prevent a crisis from happening. They're the ones that are consistently at the bedside. And again, as nurses, we fail to recognize what we do during a crisis or what we do to prevent a crisis. It's not necessarily in our job description, and along with many other things that nurses do, it's not in the job description, but it's something we all have to be aware of, that we are the ones that are going to be confronted with these crises, and we have to know exactly what to do. And if we don't know what to do, it's best to get help from other nurses until the physician does get back to you, because it may take a while. And there are my references. Okay, thank you.